So I'm going to talk about quality metrics for Barrett's esophagus, and these are my disclosures. So I'm going to talk, before I can really talk about current management, I think we really have to talk about identifying the disease, because if we're going to move the needle with Barrett's esophagus, the bottom line is we have to find the patients who have it, and we actually don't know most of those patients at this point. So, and I'll show you data for that. So once you find them, how should you manage patients with non-dysplastic Barrett's regarding quality of inspection as well as quality in sampling and surveillance biopsies? And then also who should be referred for endoscopic eradication therapy, what's the data and what's appropriate. And then we'll talk about some newly developed metrics for endoscopic eradication therapy, which is the term we use for ablation and resection techniques that are used to treat Barrett's esophagus. So really, you know, the cliff notes of what I'm about to say is Barrett's is a condition we can essentially eradicate 95% of the time. And really where we are in this field right now is figuring out who's the patients who would most benefit from this treatment and who it's worth doing. Okay, but the first question is, how do you find these patients? And one of the questions is, should you screen patients for Barrett's esophagus? The benefits of screening, of course, would be to potentially reduce the risk of developing esophageal adenocarcinoma deaths, the ability to provide patients with risk quantification based on the amount of dysplasia and the length of the segment, as well as possibly reducing their anxiety in patients who you could say, well, you don't have Barrett's. But the harms could be is that even if you have Barrett's, we don't know if our current surveillance programs are all that effective. So are you really doing the patient an advantage, okay? You're going to increase both direct and indirect costs of care. And we currently use a strategy that's focused on GERD, but in patients without GERD, you may miss those cases. There's also risks with endoscopy. There are some false positives. I'll talk about that a little bit. False negatives, and of course, the risks of labeling with regards to certain insurance issues. So that's about who should we screen. The question is, who should we screen? Well, Barrett's, we know, is present in probably between 1% and 2% of the U.S. population, which means you're probably talking 3 to 6 million people. It occurs in 6 to 18% of patients with GERD symptoms, but many patients with GERD have atypical or no symptoms. And so should all GERD patients be screened, or only some, and if so, which GERD patient should be screened? So this is some data that Doug Rex did years ago, almost 15 years ago now, that looked at patients coming in for a colonoscopy and says, hey, can we look from the top 2 and see what we find? And they found Barrett's in 8.3% of those with heartburn, but they also found it in 5.6% of patients without heartburn. And if you take a look at the orange bar, it shows that they were basically equally likely to have short segment Barrett's. So all GERD really predicts is it increases your risk for having long segment, more than 3 centimeter Barrett's. Here's another table which essentially highlights the same thing. If you look at the prevalence of Barrett's in GERD patients, which is the column on the column 3 there, and column 4, which is the presence of Barrett's in non-GERD patients, which is column 4, they're basically the same. They're not really statistically significantly different because most patients with Barrett's are short segment, and as I just showed you from the Rex paper, there doesn't appear to be any difference in short segment Barrett's whether you have GERD or not. So this is the important point, is we've spent a lot of time above water here, and we spent all this time coming up with treatments for these people that we know about. And the number of people we know about is probably 15 or 20% of the total number of patients with Barrett's. And if you're really going to move the needle, as I'm trying to say, we have to find those people that we don't know about, because I still think most esophageal adenocarcinoma presents with dysphagia and T3N1 disease, not as, oh, I developed a T1A in long-standing Barrett's. Let me go back. So, and again, this essentially, you know, GERD symptoms are not present in 60% of the Barrett's patients in a population-based study. And again, in Northern California, Kaiser found that of 589 patients diagnosed with esophageal cancer, only 23 knew that they had Barrett's for more than 6 months, okay? So who should you screen? Well, the usual things are men over age 50. We know that men are 80% of patients with Barrett's. Caucasian race, 80% are Caucasian, so 64% of patients with Barrett's essentially or so are Caucasian males. Long-standing reflux symptoms, more than 5 years, nocturnal reflux, hiatal hernia, elevated BMI, tobacco, intra-abdominal distribution of body fat. And again, it's really the more factors you have, the better the indication, but these are essentially weak recommendations based on low to moderate quality evidence. And if you take a look at the society guidelines, they're actually sort of de-emphasizing the strength of the recommendation for screening because we just don't know who to do. So there's been some models, and I won't get too much into details, but this is something that Joel Rubenstein did from the University of Michigan, comparing what are the, how do you find someone with Barrett's? You can look at weekly versus non-weekly GERD, increasing age, waist to hip ratio, and pack years per cigarette use, and all those were associated. But the biggest one was GERD in this model. So how should you screen? You can use standard endoscopy or unsedated endoscopy. Unsedated endoscopy in some studies has been well tolerated, but we don't typically do it. Capsule endoscopy, not so much. There's been some studies that have suggested it's not as useful or accurate in this situation. Or how about something non-endoscopic, potentially like cytosponge? We're one of 5 sites in the United States with this, and I'll talk about that in a minute. Or maybe we could just get a salivary or blood test, but that's really not available. So this cytosponge is basically a pill with a string on it. It's basically a cell acquisition device. You can do it in the office. It can be done by PCPs. In England, they did 504 patients. 99% were able to swallow it. 3% were diagnosed with Barrett's, which is comparable to what we'd expect here. And it actually, for 2 centimeters or more of Barrett's, had a sensitivity of 90% and a specificity of 94%. So overall, pretty good. So this may be a potential low-cost way to screen a larger group, a larger population. Maybe you'd screen all men over the age of 50 who are Caucasian, and then maybe other select high-risk groups or something. So when should you screen? The short answer is no one really knows, based on duration of symptoms, maybe based on increasing age, based on the development of increasing number of high-risk characteristics, but we don't really know. And how often should we screen, or how long should we screen? This is probably, unlike colon cancer screening, probably a one and done. This is the CORI endoscopic database looking at nearly 25,000 patients who had an EGD with a subsequent follow-up, and found that only 2.3% had Barrett's on any follow-up EGD, although the one scenario where it may be indicated is when they had esophagitis, because that esophagitis may sort of mask the underlying Barrett's. So anyways, you're going to follow those patients to resolution of esophagitis, so you can check them. So in summary for screening, which I think is really the biggest thing, the utility of screening is going to depend on the accuracy and price of the screening technique, as well as the efficiency of the techniques that are utilized once diagnosed. Screening based on GERD symptoms alone appears to miss a large fraction of patients with Barrett's, probably even the majority. And population-based screening, likely with non-endoscopic techniques, is likely to be needed in the majority of patients. And there's really sort of a limited role for repeat screening in this situation. Okay, so now we'll move on talking about how you manage patients with non-dysplastic Barrett's. And I think we can really do some quality improvement both with inspection as well as in our sampling techniques. So first of all, what's the definition of Barrett's? It's really, in the United States, it's a replacement of a portion of the tubular esophagus, typically defined as 1 centimeter or more, of the squamous epithelium in this location by specialized intestinal metaplasia, okay? So the British Society of Gastroenterology does not require the intestinal metaplasia part, so as long as you can diagnose it in England by vision, but in the United States you need a biopsy, okay? The problem, the definition though is that really it should involve at least 1 centimeter. So this here you could say, well, there's a little bit of Barrett's there, but it's probably not, because I don't think that's a full centimeter. So, again, there's a lot of irregular Z lines that are probably getting called as Barrett's. So I think it's really typically defined as 1 centimeter or more, okay? So it's important to know that where the gastroesophageal junction is, recognize where the SCJ is, and then describe the length, typically using this thing called the Prague criteria, so which I'll get to. So how do you tell where the G junction is? It's where the gastric folds end. So sort of suction the stomach down, and then you'll sort of see from the esophagus, and you'll see where the folds end there. And that's really where, I don't have a laser here, I don't think, but that's where the folds end. You can see right there on the photo on the left at the top, that's where the G junction is. And you can see it there as well, okay? So the Prague system basically allows, sort of by just writing something down, to get a mental image of what it is. So essentially it starts it's the C part. First you have to recognize the diaphragm, you have to recognize where the end of the folds are, and that distance between the diaphragm and where the folds end is the size of the hernia. And then you look where the top of the circumferential Barrett's is, and you put the number of centimeters of circumferential Barrett's there. So in this case, if the G junction's at 0, you go to 6, it's 6 centimeters. And then the top of the overall metaplasia, again, this is contiguous, so essentially connect the whole thing, is 14. So this would be C6M14 Barrett's. So part of our problem is that we don't do a great job of documenting this stuff. So this is a study looked at patients referred to our Center for Endoscopic Eradication Therapy, and this is something we did looking at data from 11 to 15. And these are the nature of the patients. Most of them, again, you can see are Caucasian and referred for ablation or resection. And what we found is that all three of those landmarks I just told you are documented only 40% of the time. PROG criteria is only used by about 1 in 4. Only half took the appropriate number of biopsies. And we ended up having to do something different than what was planned about 44% of the time because of sort of incomplete data or unexpected findings. The other thing is, in addition to detecting Barrett's, we need to inspect Barrett's. And we really need to be able to better find dysplastic areas. So there is a problem here. If you take this is a study from Amsterdam looking at 200 patients referred from 37 hospitals with high-grade or intramucosal cancer. And what they did was they looked at the reports to say, did the community physician, the outside referral, wherever it came from, find a visible lesion? And that was present in 60%. But the experts found it in 90%. So there's a large number of patients with no visible lesions that actually probably do have them. And the reason that matters is all visible lesions should be resected, not ablated, okay? And so it should change your management strategy. So this is a table from the paper. And the main thing here is there were 79 patients who did not have a visible lesion, but when they went to the tertiary center, 60 visible lesions were found, and the majority of those were T1A cancer. In fact, 45 of those are T1A or T1B cancers. So it is important for us to do a better job of identifying these lesions. So how do we do that? Narrowband imaging, I think, can help. Simplified optical chromoendoscopy is one technique. This Bing working group basically identified two main things. You can look at the mucosa and see if it looks normal or if it has absent or irregular patterns. And then you can look at the blood vessels and see if they're regularly situated or if they're diffusely distributed and don't follow normal glandular architecture. So these are all pictures of patients who have normal mucosa on NBI. And you can see in general the glands are all pretty sort of well spaced. I like to say if you're like flying in an airplane looking at a subdivision, you know, it looks nice and ordered. And then here you'll see that, well, you can see that it doesn't look as ordered. Figure A, you can see, has a lot of vessels there, maybe even a central depression. You don't see the glands as regular. So it turns out all 6 of these actually, just so you know, had either high-grade or cancer. So it can be quite subtle, and it's important to catch these lesions. And using this overall criteria, they were accurate in making a diagnosis of dysplasia in 85% of cases. And when they were high confidence in their prediction, they were 93% accurate. So that's a little bit about visualization. What about in biopsies? Well, the current technique is for non-dysplastic to take 4-quadrant biopsies every 2 centimeters. There's some debate on whether you need to do it twice a year apart initially. In fact, the most recent ACG guidelines do not recommend that. And then every 3 to 5 years. And then for low-grade dysplasia, you take 4-quadrant biopsies every 1 centimeter, and then you can repeat that every 6 to 12 months, although I would argue that the most recent data suggests you should probably ablate those or resect those patients. And then high-grade patients, again, there's 4-quadrant biopsies every 1 centimeter if you're doing surveillance, but I would argue in 2018, we do not do surveillance on high-grade dysplasia. Those should all be treated. Do we do this? Well, it turns out both in the United States and in the Netherlands, compliance is poor. In the US, only 50% of biopsies are taken according to the Seattle Protocol. When you take a look at in the Netherlands, it's even worse. You know, when you see the longer the segment, where you have more Barrett's, the fewer the biopsies are, the less the compliance. So the more there is, the worse we do. And that may be due to time, fatigue, other issues. And we actually have a paper this year, this year's DDW, which shows that using the GI Quick Registry, almost identical to the Netherlands data on many more patients. Okay, maybe you could increase it by using a brush. This is the CDX brush. This is a 40% increase in Barrett's esophagus detection in GERD patients, and also a roughly 40% increase in dysplasia detection. But a study shows that CDX alone is not as good as biopsies plus. So this is really an adjunctive technique. It doesn't get you out of taking the biopsies, you do both, okay? And then there's other technologies like volumetric laser endomicroscopy, which can give you a full 360 view and actually even laser mark abnormal areas. And so this is something that we've been doing some research into, but too early to say. So putting it all together for quality, this is sort of a consensus statement talking about sort of opinions. They could only get 80% agreement on about 3 things, and this is a little hard to read. It's in your handout. I'll just tell you, though. Basically, they said that the endoscopist should obtain multiple biopsies from the suspected area. So they agree that if you see Barrett's, you should biopsy it. And that patients who are diagnosed with Barrett's should undergo sort of some form of surveillance, and be enrolled in that. So they could agree on that. And that if you had some evidence of inflammation or GERD symptoms, you should treat them with a PPI. So they could not agree at an 80% level, though. What if you have a patient with absolutely no esophagitis and no GERD symptoms who has Barrett's? Do you need to put that person on a PPI? There was not enough agreement on that. The experts only had about a 75% agreement on that. So the next step is who should be referred for endoscopic eradication therapy. This is fairly straightforward. Most studies, high-grade dysplasia, again, is an actionable lesion. The risk of progression to cancer is between 30 and 50% in a 5-year period. The most rigorous studies prospectively suggest that that rate may be as high as 20% per year, including the New England Journal randomized trial. So I think high-grade is pretty straightforward. That's going to undergo endoscopic eradication therapy. Low-grade dysplasia, you saw numbers that were quite variable. Some said the 5-year risk for progressing to high-grade or cancer was 64%. Others said it was less than 10%. So you had kind of a wide variability. I think the key point that I want to sort of get into here is that most patients with low-grade dysplasia, when reviewed at another center or by expert pathologists, are actually felt to have inflammatory non-dysplastic. So low-grade is not low-grade until you have 2 pathologists say that it's low-grade. Okay, that's the key point. Okay. And preferably one of those should be an expert pathologist, a GI pathologist, okay? And so in the Netherlands, when they downgraded it to 85%, and they said, okay, now we're going to look at the 15% that we agree, it turns out the risk of progression is as high as 13% a year to either high-grade or cancer. And that's exactly the same number we saw in the New England Journal study as well. So in fact, the AGA just changed their guidelines to now put a more strong recommendation for the treatment of low-grade dysplasia when confirmed by 2 pathologists. The elephant in the room, of course, is what do I do with my non-dysplastics? This is a study. Well, the first thing is you say, well, we should put them in surveillance. But there's some debate on how well surveillance works. This is a well-publicized study by Doug Corley looking at Northern California Kaiser showing that patients who had esophageal cancer did not have any decreased risk from dying from that, whether they were in surveillance or not. There is some data from the VA suggesting that surveillance is of benefit, so it's mixed, but there is some data for it. One concern about non-dysplastic Barrett's is that we may be underestimating the risk. A lot of the studies exclude any cancer or high grade found in the first year and say, well, that was missed. But I think there's always some question about you can't throw the people who get cancer out because then you're self-selecting for a group of people who may be less likely to progress. The other big issue is that you really have to have a centimeter of Barrett's, and you have to biopsy above the top of the folds in order to, it's a centimeter of sort of salmon-colored mucosa. And when you look at expert review of outside endoscopies, about a third of patients who are supposed to have Barrett's don't have it. A VA study found 18% of long segment and a third of short segment couldn't be confirmed. So this is an issue. So who's high risk? Someone with a family history, long segment, or young age could be considered. Again, as well as some other factors such as prior dysplasia, GERD, BMI, or men. But in general, we don't do ablation on patients with non-dysplastics. Really, we should be focusing on finding dysplasia and doing a better job of that. So last, quality metrics in EET. This is something that with Drs. Komanduri and Wani, I've been working on, and this has actually recently been approved by both ASG and ACG. These are some of the experts that we invited to participate in this project, and this was published in July of 17. And so these are the approved metrics, and I think this is important. So if you're doing endoscopic eradication therapy or if you are referring patients somewhere, these are the qualities of the center that is doing this should have. You should be confirming dysplasia at least 90% of the time before you start. Number 2, and this is the big one, any center that performs eradication therapy should have high-definition white light endoscopy, ablation techniques, and be able to perform EMR, okay? We didn't specify if it has to be the same individual, but preferably the answer is yes, because a lot of the times you can't be sure if you're going to find a nodule or focal lesion, and you need to be prepared to do it, and it's really not right for the patient to have to come back a second time. Of course, you want to have consent and discuss the risks with the patient at least 99% of the time. You want to make sure you use that PROG system at least 90% of the time. You should report if there's any visible lesions 90% of the time. You should use high-definition white light endoscopy at least 95% of the time, which is hopefully something every unit has. And if you see a lesion, you should remove it with mucosal resection. Intra-procedure metrics again, other additional ones are, once you do endoscopic eradication therapy, you have to tell them when they need to come back. And again, we actually put most quality measures are always sort of processed, like, did you do something or not? But this is a hard outcome. If you're doing this, you should be able to get rid of all the neoplasia, all the dysplasia neoplasia in 80% of patients within a year and a half, okay? If you're not doing that, you have to wonder what's going on. Same thing, you should get rid of all the Barretts in 70% within 18 months, okay? And then once you've gotten rid of it, you need to continue surveillance because we do know that there's a risk of it coming back between 8 and 13%. A lot of it's dependent on whether you control the reflux or not. So it's important to continue their anti-secretory medications. During surveillance for EET, you should biopsy any visible lesions you see during the follow-up. They should be on an anti-reflux regimen, and you should track your adverse events. And you should all do that between 90 and 95% of the time. So again, this is a study showing outcomes of incomplete responders. This is why we have you recommend anti-secretory therapy. In patients with a complete eradication of intestinal metaplasia, you see about, there was 45 of the patients who there was 48 patients who didn't respond, and after they got their modification of their medical regimen, they were able to get eradication. So, and most of the time they just needed one additional treatment to do it. So you have to control the pH in order to get rid of it and to keep it away, okay? And then this is a paper from Dr. Komanduri in the American Journal of Gastro this last year showing their regimen of how they do this, and I won't, in interest of time, discuss that. So in conclusion, the current screening strategy for Barrett's has not shown clear benefit. The optimal method for screening for Barrett's is uncertain, and future approaches may benefit from using a lower cost initial method and screening a larger population. Greater attention needs to be paid regarding proper endoscopic inspection, landmark documentation, and looking for focal lesions, as well as biopsy protocol. And again, endoscopic ablation and resection should be discussed as a treatment option, I would argue, for all patients with confirmed dysplasia, and we now have some quality metrics on how to perform endoscopic eradication therapy. So I wrote this almost 8 years ago, and I guess you could say it's a sign of how little progress that we've made. It probably still holds today. Our goal is to get a non-invasive test for Barrett's that will hopefully non-endoscopic, either salivary, blood, maybe the cytosponge. If it's negative, you're done. We said screening is kind of a one-time thing. If it's positive, you'll get an endoscopy, which will either confirm or deny it. And if you're confirmed, we'll hopefully stratify you based on some biomarker panel, which we don't have, or a clinical risk panel, which we also don't have. But if you were low risk, we could tell you to forget about it. If you were high risk, we'd proceed to endoscopic eradication therapy. And if you're intermediate, we'd do chemoprophylaxis or surveillance. All right, so with that, I'll stop, and thanks for your attention.